Hello everyone. Thank you for being here and welcome to this webinar on nitrous oxide sedation. Our topic today is occupational safety and practice management. My name is Frank Mathers, and together with my colleague Leanne Kiefer, I'll be conducting this seminar. This is part 3 of a trilogy on nitrous oxide sedation, and I encourage you to check out the previous 2 webinars if you haven't already done so. They're available on demand right here on the Viva Learning website. Today's webinar will also be made available on demand in about a week or so. What happened so far? Well, Leanne conducted the first seminar in July and explained to us in detail the science behind anxiety in the dental office, how to identify it, how to manage it, and gave us some very practical strategies. Then just a few weeks ago, I held a seminar on nitrous oxide in dentistry, concentrating on the various stages of sedation, the pharmacology, indications, and contraindications of nitrous oxide. We had very interesting discussions with you following each of the previous 2 webinars, and I'd like to encourage you today to actively challenge Leanne and I and to actively take part in the question and answer segment later on. The first 2 presentations of this trilogy dealt with our patients. Leanne gave us the background information to manage anxious patients and identify candidates who required pharmacological intervention like inhalational sedation with nitrous oxide. And in part 2, I spoke about the technique of nitrous oxide sedation. So up to now, we spoke exclusively about the most important topic, our patients. Today, we're going to be talking about us, the healthcare team. I'll be presenting part 1, occupational safety in a broader sense, which should take about half an hour. Then Leanne will take over discussing practice management, and we'll end the webinar with the question and answer segment. All in all, I think we should be here for about an hour. We'll be talking about us and our physical health, namely our occupational exposure to the anesthetic gas nitrous oxide, us and our mental health as it pertains to nitrous oxide, which is a substance of abuse, and when it is abused in the long run, it's usually by dentists and people who work in a dental office. Us staying out of trouble, and in particular, I wanted to talk about informed consent. In part 2, Leanne will be discussing us building a future for our patients, ourselves, our team, and our families, specifically practice management strategies to achieve those goals. And in preparing today's presentation, we went over the discussions that we had with you during the previous seminars, and I'm sure that today's event will be highly interesting to everyone because many of the questions and comments that you had during the previous webinars have been incorporated into today's presentations. Leanne and I have done our best to give you a comprehensive overview of the topics that we will be discussing, but you can only do so much in an hour's time. And as I have recommended previously, for more in-depth knowledge on these topics and other topics concerning nitrous oxide, I highly recommend this book written by Dr. Clark and Professor Brunick. It is the standard medical textbook on this subject. So let's get started talking about us and our physical health or our occupational exposure to nitrous oxide. Leanne and I feel very privileged to have a worldwide audience for these presentations. It's wonderful to get all of you dedicated medical professionals together from around the world. And when it comes to rules and regulations in medicine, I think that the general themes are valid worldwide. On the other hand, of course, each country and even individual states within countries have their own nuances, and you'll have to consider that when practicing medicine and conducting nitrous oxide sedations. But like I said, I think the general trends are the same all over the world. So I will be concentrating on the rules and regulations here in the United States during this presentation today. One of the most important institutions that we have when it comes to occupational safety and health is OSHA, which is a department within the Department of Labor. Nobody loves government regulators, but we do have to be thankful to know that we now have about half of the fatalities and about half of the worker injuries that we had before OSHA was created in the early 70s. OSHA is a government agency, and their task is to protect the workforce. They have several different divisions. Among others, they have divisions for healthcare specialties, and they're a law enforcement agency of sorts in that they can issue warnings or even fines up to an amount of $70,000. They're responsible for every working person, except minors, transportation workers, the self-employed, and public employees. If you take a look at the healthcare hazards that are in the focus of OSHA, it's mainly infection control, infectious diseases. You can see needle sticks and bloodborne pathogens here. Also, they have an eye on the environment in which people are working, so electrical hazards and so on and so forth, which doesn't really pertain to us that much, but if you take a look at their surgical suite concerns, then we're getting a little bit closer, because here you find the waste anesthetic gases that they are keeping an eye on for us. Another agency that's involved in worker safety here in the States is NIOSH, and NIOSH is located in a totally different area of the government. They are a part of the Centers for Disease Control, and NIOSH has even more detailed ideas on what limits should be enforced when working in an environment where anesthetic gases are being used. But you have to consider that they are mainly interested in knowing your anesthetic gas inhalation, because they want to know if you might be possibly impaired and then cause damage to a patient. So they're keeping an eye on waste anesthetic gas because they're afraid you might be inhaling anesthetic gas and then becoming nauseous or dizzy or have some sort of cognitive impairment, and then not being able to care for your patients in a prudent manner. Only as a sidekick are they looking at problems that are associated with you and I, for instance, sterility or miscarriages, birth defects, and organ damage, and so on. So we have two different agencies that are responsible, and they have different focuses. OSHA creates regulations, and they enforce regulations. So OSHA is sort of like the police force, and NIOSH is a research and educational institution. So the NIOSH will analyze data and conduct research and then make recommendations to OSHA, who will then come up with regulations and then enforce them. So that's how that works. Talking about research, I don't know any area of medicine where you will find more chaos and controversy than in the area of nitrous oxide and the question um, of does nitrous oxide cause any damage to us who work in medicine? And I think it all started out in 1967. In 1967, a Russian researcher, Weissman, conducted a study where he gathered data from operating rooms around the country where various techniques of anesthesia were conducted. And what he did find is that the people working in anesthesiology in these institutions did have reproduction issues, both the men and the women. And in analyzing the data, he only found one factor to be a common denominator among all of the anesthetics that were given, and that was nitrous oxide. So he said, well, if everybody was using nitrous oxide and this population has issues of reproduction, then it must be the nitrous oxide. So I don't know if you can come to a simple conclusion like that today. In the States, Cohen began conducting research in 1970, and it peaked with a large study in 1980 where he did 50,000 telephone interviews with dentists and dental assistants, and he also found that there were issues concerning reproductive medicine among this population. He also then concluded that it must be the nitrous oxide. Although he didn't actually go into the dental operatory and measure the ambient air for nitrous oxide contamination, it was only telephone interviews. He still, based on these telephone interviews, came to the conclusion that nitrous oxide was responsible for problems of reproduction. Then came another study, also in the 70s, that was really interesting because this study showed that subjects that were exposed to very, very, very low concentrations of nitrous oxide, namely 50 parts per million, and I did the calculation for you there in the middle on the right. 50 parts per million is equal to 0.005% nitrous oxide. And in this study, there was audiovisual impairment found in subjects that were inhaling that dose of nitrous oxide. And many of you use nitrous oxide, and you know that most patients in dentistry will require between 30 and 50% of nitrous oxide, and that would be equivalent to 300,000 ppms to 500,000 ppm. So, I mean, just from working on a daily basis with nitrous oxide, it's hard to believe that someone who is inhaling 0.005% of nitrous oxide, that they would be impaired in any way. And actually, when others tried to reproduce the study that was conducted, they couldn't. And it ended up being retracted. So with all these studies going on and all these discussions going on, NIOSH, the academic institution, did come up with a fairly arbitrary threshold, a limit that was to be not to be exceeded within dentistry. They initially came up with a limit of 25 parts per million for hospital operating rooms and 50 parts per million in dental operatories, but later on it was set to 25 parts per million everywhere. And OSHA, the police force, then took this recommendation from NIOSH, but it's not being enforced. So OSHA also recommends this, but they don't enforce it. And so with all of this going on and nobody really knowing what the story is over decades, the first person to really take a serious scientific look at the whole situation was Dr. Clark in 1995. And Dr. Clark is the one who wrote the book with Professor Brunick that I told you about before. So Dr. Clark analyzed the world literature, found 850 studies on this topic, and out of those 850 studies, he built 23 that had the highest quality data to do his analysis. And he was looking for a limit that's based in science where a clear indication was given that it could cause health problems in us. And he found nothing. He could not come up with a number. He could not come up with a scientific basis for the limits that were set by these government agencies. We have a different situation in patients receiving high concentrations of nitrous oxide over extended periods of time. And that goes way back into the 50s, where they ventilated patients in critical care units with 50% nitrous oxide over weeks and months because they needed to be on a ventilator due to tetanus. What was found there is if you have someone inhaling 50% nitrous oxide 24 hours a day over weeks, then you will find anemia and you'll find permanent neurological damage and other things. And it was traced back to the fact that nitrous oxide in high concentrations like that over extended periods of time will cause vitamin B12 deficiency and folic acid deficiency. And the vitamin B deficiency is responsible primarily for the neurological defects. These people will show irreversible polyneuropathy. They'll have numb extremities and they'll have degeneration of the dorsal lateral spinal columns. So they have permanent long-term neurological damage. Interestingly enough, the people nowadays that develop these problems in association with nitrous oxide are patients who abuse nitrous oxide because nobody else will inhale high concentrations of nitrous oxide over weeks, months, and oftentimes years and decades. So we will be talking about this a little bit later once again. Folate deficiency. Folate is also inactivated by nitrous oxide. Folate deficiency will primarily affect the hematopoietic system, causing anemia. These people are pale, they have low white cell counts, are prone to infections, and also have bleeding disorders because they have thrombocytopenia. Nitrous oxide does cause vitamin B9 folate deficiency and B12 deficiency because it inactivates both. And that does have relevance for us because in pregnancy, especially in the first and second trimester of pregnancy, folic acid is necessary for organ formation. So that's the basis for the recommendation not to use nitrous oxide in the first and second trimester of pregnancy because it will have negative consequences on the developing fetus. In the third trimester, nitrous oxide is being more and more commonly used. I know in the UK they have used it for decades to relieve the pain of labor. It's becoming more and more popular here in the States and also in mainland Europe to use nitrous oxide for labor pain. Also, female employees that are pregnant also should not be in contact with nitrous oxide if possible. At the very least, they should know what their exposure level is, so it should be measured, and they should ensure that systems are being used that will scavenge excess nitrous oxide. I know in some European countries, personnel that is pregnant is not allowed to work in the operatory if nitrous oxide is being used there. They can work in the office, but not in that specific operatory where nitrous oxide is being used because of these health concerns due to the inactivation of folic acid. So in all of this uncertainty, what guidance are we getting from the government and from researchers? Well, OSHA doesn't have an official standard for nitrous oxide. NIOSH recommends a limit of a fairly arbitrary limit of 25 parts per million. It used to be 50 in dentistry, it now is also 25 parts per million. These two institutions, like I said before, have more of a focus though on our performance. They don't want us to be exposed to higher levels of nitrous oxide because they don't want us to become impaired and harm the patient. So they're not so much worried about any adverse effects on our own health. I think one factor is important, and that is to know if we are even being exposed to nitrous oxide or not. And there's only one way to know, and that's to monitor the ambient air in the operatory. So how do you do that? There are two basic techniques, and I recommend this to every dental office that conducts nitrous oxide sedations. The two techniques are spectrometry and dosimetry. The dosimeters are fairly easy to use. This is one model. There are different types. There is one that looks like a miniature Tupperware bowl that you can open and close. You open it when you're working in an environment with nitrous oxide. You can close it back up. In the end, you send it in to the lab, and then they will do an analysis for you and give you your exposure to nitrous oxide. They cost about $60 a piece. The second method that I'm sure only few private dental offices would have is using a nitrous oxide monitor. This is one that costs about $4,000. There are cheaper ones out there, but beyond the cost of buying one of these monitors, you also have to maintain it. And here on the right, you can see calibration gases that you need to use to calibrate these monitors. I think most dental offices will probably stick with the lower cost dosimeters. So what does the American Dental Association recommend? They do recommend that you monitor your office with a nitrous oxide analyzer or a dosimeter, and their recommendation is, and it's only a recommendation, their recommendation is to check your ambient air twice a year. And you can either wear one of those dosimeters, or you can also hang it up. If you have like one operatory where all of the nitrous oxide sedations are being performed, you can use the dosimeter in that operatory. It doesn't necessarily have to be tied to a certain healthcare worker. The American Dental Association highly recommends using a scavenging system, and the scientific research certainly shows enough evidence for that, because the contamination levels are way lower if a scavenging system is being used. And the gases should, of course, be vented outside of the building, not inside the building. And one uh, important factor too is that you should try to minimize patient conversation, and that's not always all that easy, especially with kids. But if the patient is receiving nitrous oxide sedation and starts talking to you, they're blowing the nitrous oxide right into your face and you're breathing it. So that's not a good idea. You should always keep an eye on your equipment, and the ADA recommends testing your equipment monthly to see if there are any leaks. All of this is geared to keeping your levels below 25 parts per million, and that's on the over time. Now I'd like to talk about us and our mental health, uh, and in particular, healthcare provider nitrous oxide abuse. And like I said before, nitrous oxide, when it is abused over long periods of time, I'm talking about years, it's mostly people who have access to it, and who has access to nitrous oxide? Dental personnel. So that's why I think this is important to talk about for us. There are several different models of drug abuse and why people become addicted to drugs. The most popular um, model today is the biopsychosocial model, which states that there are three basic components that will cause someone to become addicted to a drug. The one component is genetics, and also another biological component is the dopamine reward circuit in the central nervous system. The second one is psychological influences. People who are depressed under a lot of stress and have a lacking sense of control, a lacking sense of purpose, are more prone to develop a drug addiction. And of course, the social environment in which people live will also contribute to the probability of someone developing a drug addiction. If you take a look at what drugs are being abused, you might be surprised to see that it's 10% of those drugs are inhalants. Only a very, very, very low percentage of that 10% is nitrous oxide. They're talking about gasoline, paint thinner, nail polish remover, glue, and other inhalants that are abused more regularly than nitrous oxide. Nitrous oxide is a party drug, and you can buy these balloons for like €1 in European discos, I'm told. And I got these two pictures from a newspaper in the UK where they showed these partiers inhaling nitrous oxide from a balloon. And the biggest complaint about it all was the littering of the London parks with all of these balloons, causing the neighbors to submit complaints to the city to put a stop to it all. These kids are not going to go on to develop a nitrous oxide addiction just because it's not very practical to apply nitrous oxide over extended periods of time with this method. And also the balloon, of course, has 100% nitrous oxide and no oxygen, so they'll have like 3 or 4 minutes of fun with that, but that's going to be about it. Here's the potential to develop an addiction with various substances. And I put this slide in here mainly to show you that nitrous oxide does not belong in the same area as highly addictive substances like OxyContin or other opioids like morphine or heroin or cocaine or even alcohol. Nitrous oxide is located next door to coffee. So it's not a substance that is easy to get addicted to. So what is a substance abuse? Well, it's the uncontrolled use of a legal substance like nitrous oxide, the use of an illegal substance, and the common denominator is that it will ruin your life. It will impair the patient at work. It will have a negative impact on their personal life. It all in all is a downward spiral. So that's the common denominator. There's abuse of substances, abuse of drugs, and there can be a dependence on drugs. The dependence can be physical, and the physical dependence on a drug coincides with physical symptoms of withdrawal that can be life-threatening. Benzodiazepines come to mind, but also other substances. Alcohol, if you have an alcoholic who can't get his alcohol, they're going to show vegetative symptoms like sweating, tachycardia, and fatigue and delirium. So that would be physical dependence. As opposed to psychological dependence, where if you have a substance that only causes psychological dependence, then you'll have withdrawal symptoms that are more emotional. These patients will show symptoms of depression, for instance. Nitrous oxide is a drug that would cause psychological dependence. So these patients who abuse nitrous oxide will not start sweating and shaking if they can't get their nitrous oxide, but they might get depressed and dysphoric. And addictions will lead to secondary psychological phenomena like depression, anxiety, psychosis, mood swings, the list goes on. And if you take a look at this slide, though, the question here also arises, which came first, the chicken or the egg? Because these psychological or these psychiatric diagnoses can in themselves be contributing to an addiction. So sometimes it might be hard to keep that all apart. So what are the stages that someone would go through in becoming addicted to a drug? It all starts in a very friendly manner. The person tries out the drug and finds out that it gives them a good feeling, it has positive effects. In the next stage, they would seek out that positive experience. And as time goes on, the patient would notice that they're going to need higher doses and will no longer be getting the positive effect that they're hoping for. And as that continues, then they start into this downward spiral where they're also ignoring the negative effects that the substance abuse is having on their life, on their work life, and their personal life. And then comes a point where the patient will realize that they are hooked and will try to break the addiction, but then will notice that they're powerless to do so. So that's the downward spiral that people take to develop an addiction. So what does treatment look like for healthcare providers? And I specifically mention healthcare providers here because there are no non-healthcare providers that are addicted to nitrous oxide. Few of us who are addicted will voluntarily go for treatment. What is necessary is a force from the outside. So the addictive behavior has to be forcefully interrupted. It's not going to stop by itself. And that has to be monitored over a long period of time. Most programs that were developed run over a 5-year period. And it's important that the patient or the healthcare provider in this scenario stays compliant for 5 years. And if that is not the case, and the patient chronically relapses, that would be a problem, and that would probably lead to a loss of their license. Now I'd like to talk about us staying out of trouble, and I have a few comments on informed consent. And when you talk about informed consent, you're immediately also talking about lawsuits. So why do patients want to sue you? They're angry and disappointed. They're angry and disappointed by the results that they got, or they're angry and disappointed by the price that they had to pay for the care that they got. Sometimes they really do get a bad result, and sometimes malpractice might have actually even occurred. And when attorneys look at these cases, what are they looking for? Take a look at number one. They're looking for inadequate documentation because that opens the door for everything. Of course, there are other factors that are important to follow, but inadequate documentation is always a great thing for a lawyer to find if they want to sue you. So if you want to avoid legal action, good documentation is number one. Getting informed consent for sedation and for procedures would be number two, and showing good bedside manner. So what's the standard for informed consent? The disclosures to the patient should be what a reasonable patient would expect to know in order to make a decision about a procedure. So the patient should get general information on the nature of your treatment, along with a description of the material risks and possible alternative treatments. And all of this has to be well documented, because that is what will prevent a lawsuit from happening. And if one does happen, it will lower the settlement demands. And we all remember that if it's not in the record, it wasn't done. What are material risks? It's been debated over the years. It's not very well defined, and it's defined as what a reasonable person would consider to be significant in coming to a decision as to whether or not they should go along with the treatment that you have proposed. So that being fairly arbitrary, everyone would recommend, if you're going to err, then to err on the side of over-informing the patient than on leaving out pertinent information. So to summarize informed consent, as far as it pertains to nitrous oxide sedation, you should always have the conversation with the patient and get the consent sheet signed by the patient. That's not a legal requirement. You don't have to have a signature, but it's generally recommended, and I'm sure that you do that already. You should write directly in the chart that you did speak with the patient and informed him. about the risks, possible alternatives, and most dental offices will have standard forms printed up for each procedure that are being conducted in the office, and nitrous oxide should be one of those procedures. So have that ready printed. And with that, I'd like to turn you over to Leanne, who will talk about us building a future for our patients, ourselves, our team, and our families, and give us some tips on practice management success. And I'll see you all later in the question and answer section when Leanne wraps up. Thanks for listening.
Good afternoon. Thank you, Dr. Mathers, for your insight into occupational safety. My name is Leanne Kiefer. I'm Director of Education for Crosstex, a Cantel medical company, who is sponsoring this series of programs. As we discussed in the first webinar, pain is a major factor that brings some patients into the dental office, where concurrently fear and anxiety about that same pain are common reasons that patients fail to seek dental care. In a 2016 white paper that was published by the American Association of Oral and Maxillofacial Surgeons, it was stated that the magnitude of the public health problem is indicated by the fact that 35 million Americans avoid dental treatment until forced into the office by pain such as a toothache. So obviously the control of pain and anxiety is an essential part of our dental practices, and many dental offices, both general and specialist, rely on nitrous oxygen sedation for its anxiolytic properties. And if you consider that 35 million patients, that's a very significant potential patient pool. Just to briefly look at the equipment that's used for the delivery of nitrous oxide oxygen inhalation sedation, it's actually quite simple. Primarily, this equipment consists of a supply of gases and an apparatus for the delivery to the patient. We're going to be talking in a little bit more detail about some of those capital costs. While the manufacturing process of nitrous oxide is very inexpensive, it also provides an excellent product that's very affordable for use in healthcare. The nitrous oxide and oxygen gases are packaged into cylinders that are delivered to our dental offices. And these cylinders and machines can be portable, or they can be fixed and connected to a central system within the office. The portable systems use a yoke stand onto which they call them the E-size nitrous and oxygen cylinders attach. And certain clinicians may actually have a personal preference for this smaller footprint rolling type of system that can easily be moved from treatment room as needed. These yokes may hold up to 2 cylinders, one for nitrous, one for oxygen, or they may hold up to 4 tanks, 2 nitrous and 2 oxygens. The benefit of this system is that the initial setup costs are lower than the cost of a centralized system. This portable option would complement a practice when they only occasionally use the nitrous oxide oxygen, or when space is limited within the physical office and it doesn't allow for a centralized installed system. You want to remember that the E-cylinders are smaller, they store less gas, and tend to be more expensive per unit than do the larger H and G cylinders. So if nitrous oxide oxygen sedation will be a common practice within multiple treatment rooms in your practice, a central supply system may be the best option for a number of reasons. This centrally plumbed system allows for multiple flow meters to be placed in each of several treatment rooms. However, you have to remember that the planning of the piping and the connections are important during the office build, as this is the most cost-efficient way as compared to retrofitting it into the space. The central system avoids having to move machines and hoses from room to room. And additionally, we said the larger cylinders allow for larger quantities of gas to be stored as well in a remote location outside of the patient treatment area. The larger H and G cylinders are much less expensive per unit of gas than the smaller E cylinders. One thing I want you to remember, that though the initial setup costs are high, the centralized system is more cost efficient in the long run, and it's just a little bit easier with the centralized systems. It's convenient. It minimizes the need to change tanks as frequently. I'm going to give you a little bit of information about additional costs to consider. Sometimes people look at these as hidden costs. And any numbers or figures that I cite are examples only and may vary from region to region. Some of the things you want to think about are the distance from the distribution center, from the gas center, because there could be a delivery, and oftentimes it's a flat fee. Sometimes it's something like $15, regardless of the size of the cylinder that's been ordered. There may also be a flat fuel surcharge, which may be between $5 and $10. They may charge a hazmat charge somewhere in the vicinity of $20 to $25, and there are different vendors that will simply list it as an exchange fee and round it, and it may be rounded to something like $150. You may also take into consideration that there would be an annual cylinder lease, and you would renew it every year, and sometimes those between $90 and $100 for each cylinder. Last but not least to consider are maintenance costs. And the manufacturers of your delivery systems, whether they're centralized or portable, have recommended routine, preventive, and annual servicing of the various units. So you always want to refer to your manufacturer's IFUs for the specific time frames for each maintenance procedure. And by taking time to follow these recommendations, it helps to ensure the safe delivery for the patients as well as the occupational safety of the staff. The service procedures for a delivery unit may also include things like recalibration, pressure testing, internal component evaluation and replacement, or something as simple as checking the integrity of the reservoir bag if there is one, looking for punctures or splits. And as always, the inspection or servicing and repair must be done by a qualified technician. This comparison chart was shared with me by Dr. Tony Carosha, who practices in Clarksville, Tennessee, and he presents frequently on nitrous oxide at the ADA, the AGD, and various other regional meetings. And these are the figures based on his practice in Tennessee. And if you just sort of skip down and scan to the last line, you're going to see the average cost between the smaller E cylinders compared to the G or H cylinders can actually be 3 or 5 times higher. We're not going to go into detail on the various specific patient delivery devices, including the nasal hoods, cannulas, and the combination units of the hoods and the cannulas, but just know that there are many options that are available for patient delivery. And the preference is for patient safety and comfort is to use single-use disposable masks, which are available in a variety of designs and sizes and unencumbered access, with a small lightweight scavenging system, which is easier for us to work around than the traditional larger nasal hoods and the corrugated hoses. Again, this simple design change contributes to more efficient care and time savings. And while there are some traditional masks that are opaque, some of the newer hoods are translucent, and it allows you to visually monitor your patient's breathing more easily. Dr. Mathers referred to the dental Bible, so to speak, which is the Handbook of Nitrous Oxide and Oxygen Sedation. And authors Clark and Brunick posed these 2 questions. Do you consider your patient's comfort levels valuable? Are you less stressed because you have relaxed cooperative? And while these questions are rhetorical, the reality is that any financial investment that's made in the practice will quickly be recovered, because a patient's sense of well-being following dental care is our ultimate goal. The use of nitrous oxide and oxygen in dentistry offers the opportunity to many patients with dental fears or certain medical or mental conditions to get the treatment that's needed. Minimal to moderate sedation levels, as with nitrous, will be less costly than, say, deeper or general sedation. According to a 2012 survey conducted by Penwell, more than half of dental offices charge an additional fee above and beyond the standard fees for nitrous oxide administration. And you can see that there are various procedures listed here. So the nitrous oxide, 58% charge an additional fee. Let's look at this a little bit more. As we know that healthcare costs continue to rise and many of our patients don't have optimal dental insurance benefits, concurrently, when those dental problems arise, sometimes the emergency room is often where these patients seek help, and the cost for this treatment can be significant, especially if they've been admitted or treated in a surgical center. These emergency visits could be avoided by early intervention in a safe and economically reasonable environment using minimal sedation, like nitrous oxide, to reduce the patient anxiety and to gain better compliance with dental treatment. As a side note, the cost across the U.S. for delivery of nitrous oxide ranges between $0 and $200, with an average fee, again average, of $55. We know that the coverage with the ADA code of the 9230, the coverage does vary by zip code between the major insurance providers. Often patients are willing to contribute out-of-pocket expenses for the ability to be treated with nitrous oxide. One of the things that's currently being looked at and discussed with this code, because right now the ADA, the 9230 code, is basically a per visitor, per procedure. It doesn't matter if it's adult or child. One of the things that Dr. Charlie Blair refers to is the definitive written documentation that can help to secure the reimbursement. So you want to make sure to take the time to observe and listen to your patient to be able to accurately document their level of anxiety and/or their level of fear. There are discussions of adding a new code that would be an addendum to the 9230, that for procedures that would run longer than, say, an hour procedure, it might be something like for additional 30-minute time frames, they may then use the additional code to help cover the additional expense of the nitrous oxide oxygen delivery. Again, Dr. Karosha shared from the Tennessee practice zip code that he's in. We talked about the average is $55, and we've listed some of the major dental and health insurance carriers, and you see what the reimbursement figures are within that region. Another thing or investment that we need to consider with best practice of nitrous oxide oxygen sedation is the education and training that's required in order to be able to administer and monitor. For dentists, dental hygienists, and dental assistants, there is an initial course that's going to be required. There will be different times of didactic and clinical experience within that additional course that provides certification. And then there are some states that require recertification on a periodic basis. The recertification courses are usually shorter in time frame than the initial. Additionally, there may be a fee to the practice charged by the state for a certification fee to deliver in the office, and there may be a fee from the state to have a certificate posted in the office that nitrous oxide can be delivered. I pulled up two different references, and these are available online, so don't scurry to try and write them down, but this is from the ADHA, and it outlines by state which states hygienists are able to administer or monitor nitrous oxide. And for hygienists, we have 32 states that we can become certified to administer. There are 2 states that the RDH can only monitor, that being New Jersey and Florida. And there are 16 states that are not participating currently with dental hygienists with monitoring or administration of nitrous oxide. Concurrently, the Dental Assisting National Board, or DANB, provided me with this document, and there are 32 states that a dental assistant, once they've taken the appropriate certification, can monitor nitrous oxide delivery. There are 7 states that a dental assistant can induce or administer And there are 13 states that a dental assistant can assist in administration. There are 13 states that monitoring is not addressed at all for the dental assistants. And then finally, of the 35 states, they require certification or coursework, not only for the nitrous oxide course, but also either for CPR and or basic life support. And if you'd like information on these two documents, I will give you my email at the end of the program, and you can request it from me. I'll be glad to share that with you. We start looking back about what are the benefits, and dental clinicians agree that anxious patients can be very difficult to manage or treat, and many of us feel feelings of frustration or inadequacy leading to increased stress when we're treating anxious patients. Also, the anxious patient is more likely to be late and is 3 times more likely not to show up for their appointment at all. These patients also typically take up 20% more of our appointment time. So, with appropriate use of nitrous oxide, what happens? As Dr. Mathers just discussed, nitrous oxide is the most commonly used inhalation sedative in dentistry, and it has an excellent safety record. The important things to think about are being able to observe and listen to your patients so that you get that identification and selection of the appropriate patients that could benefit for the use of nitrous oxide. Sometimes it's something as simple as just ask. You know, would you be interested in adding nitrous oxide to your treatment plan to help alleviate the anxiety and create a positive experience? Sometimes it's just simply asking the question. Because when these patients experience a sense of well-being and of successful care, they're going to refer their friends or their family to you. And based on their conversations with your patient, many of these new patients will proactively request nitrous oxide for a more relaxed dental appointment. When we talk about the value conundrum of cost savings versus revenue savings, either way, you're going to be improving your profit margin. Cost savings are always easier to quantify. The more efficient treatment time reduces overhead and provides the opportunity for more efficient patient scheduling. You may end up with actually an extra patient slot at the end of the day. Just to give you some thoughts and trends to think about, currently in the U.S. we've got about 180,000 practicing dentists. 80% of them are general dentists, 3% are pediatric dentists. About 40% of the general dentists are currently using nitrous oxide oxygen sedation. In the U.S., we have a birth rate of about 4 million people annually, and the prediction is that by 2020, we're going to have 80 million people that are going to be 18 years of age or younger. And so for those practices that have not been incorporating children or have been moving children out of their practice, you know, this may be a consideration for the increased use of nitrous oxide oxygen sedation within the practice. And I'm sure you've all seen on the news the nitrous oxide last August shortage occurred after there was an explosion at a production facility in Florida. And this occurred during routine loading. A tank actually exploded in the loading bay. It was on the 29th of August last year. And there were 2 tanks and a larger holding tank that were destroyed, and also, unfortunately, an employee lost his life. There's only a small number of nitrous oxide producers in the U.S. and 1 in Canada, which right now also temporarily is out of production for a short period of time. The FDA first issued a shortage notice on January the 19th of this year for nitrous oxide cylinder gas, but they stated that a return to full capacity was anticipated by the end of March 2017. We then again saw a prediction that it was going to be in July, and then most recently we just had an announcement come out from the FDA about the shortage. If you have a shortage to report in your area, this is a website that you can use to report any challenges in being able to procure nitrous. So most recently, this was in the ADA news from the FDA. They posted the notice that the nitrous oxide shortage continues, and it's unclear when full production will return. And while an FDA spokesperson was not able to provide a specific date regarding return to full capacity, the company anticipates a rebalanced supply chain in the near term. And with that, That concludes the primary part of the presentation. I'm going to give you a little review of the webinar topic summary items that we've covered over the past 6 weeks. We provided dental fear and anxiety. We talked about the clinical science and application. Dr. Mathers addressed occupational safety earlier today, and we finished up with practice management. At this point, I'm going to release control back to Dr. Mathers, and he's going to begin addressing some of the questions that you may have regarding any of these 4 topics. If you don't get the chance to get your question answered, if you would like to send me the question to my email address, which is leannk, that's LEANNK, @crosstex.com, I will do my utmost to be able to answer any of those questions. Dr. Mathers, I'm going to turn it back over to you.
Okay, thanks, Leanne. Thanks, Ann. I still waiting for questions to come in. Mm-hmm. It doesn't look like we're having that many questions this session. Oh, okay, here we go. Well, it looks like we don't have that many questions. That means that we did a good job, I guess, Leanne. Thank you very much for being here today, everyone. We appreciated your participation very much and look forward to seeing you on, oh, here, just a sec. Melissa, I don't understand your question. What is the difference between monitor or assist with nitrous oxide for dental assistants? I think I will give that back to Leanne because I'm not sure myself. I don't think there is a difference. Back to you, Leanne.
Melissa, I'm happy to refer you. The explanation for that is quite lengthy, and I'm happy to provide you with the written documentation from Danby that would clear that up on the states that there is that differentiation. So if you'd please send me an email, I'll be glad to have that available to you. At this point, I don't think we have any other questions, so I want to thank everyone for supporting us during the series of the 3 nitrous oxide courses, and these will be available on demand at crosstexlearning.com as well as through Viva Learning. Thank you so much for your time this afternoon.